गुड आफ्टरनून डॉक्टर शरीफ।
गुड आफ्टरनून सर, कैसे हैं?
बस मैं ठीक हूँ, आप कैसे हैं?
मैं बिल्कुल सही हूँ सर। स्टार्ट करेंगे सर हम लोग 2 मिनट में।
हाँ, 2 मिनट में करते हैं स्टार्ट।
जी सर, जी सर।
मैं भी कुछ लोगों को फोन कर दूं जिसे और थोड़े से ज्वाइन कर लें।
जी सर, जी सर।
Should we start?
Dr. Alok, can we wait for some more time because my Dr. Srish is facing some internet issues. He will be
Okay.
joining in some time.
Okay.
Let us wait for 5 more minutes, please.
Okay. Okay. No problem.
In the meantime, you can ask others to join, please.
Okay. Okay.
सर थोड़ा डिस्कनेक्ट हो गया था, स्टार्ट करें सर?
हाँ, स्टार्ट कर लेते हैं.
यस सर.
So, welcome Dr. Shirish. He will be speaking on role of probiotics in dysbiosis. So, over to Dr. Shirish. Please start.
Thank you. I'm just switching off the video because the internet is not good. So video नहीं चला पा रहा हूँ सर.
अच्छा,
इंटरनेट जो है बहुत फ्लक्चुएट कर रहा है सर.
अच्छा 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 अच्छा.
हाँ, तो इसलिए वीडियो ऑन नहीं किया है.
चलिए, कोई बात नहीं.
ठीक है सर. मैं लास्ट में जब क्वेश्चन आंसर्स होगा तब मैं वीडियो ऑन कर लूंगा सर.
ठीक है ठीक है ठीक है.
Okay. Thank you everyone. Thank you Alok sir for giving this opportunity. ALIGARH is my कर्म भूमि. I have learned everything from ALIGARH itself. मेरा MD वहीं पे, MBBS MD सब यहीं का है. So and Dr. Anuj is also here. So thank you Dr. Anuj for giving this opportunity. So I'll be going through basically what are the clinical aspects of probiotics. Not going much into the science behind, क्योंकि वो बहुत थोड़ा सा हो जाता है कि microbiota ये सब में नहीं. I'll be trying to focus on the clinical aspect and what is the ideal probiotic, how to choose an ideal probiotic. So what we see that probiotics initially अगर आप देखें तो पहले 17 years में 1983 से 220 तक there were only 3,480 papers. But now there is a trend of finding a role in probiotics in every disease and every condition. And if you see in last 7 years, we have published around 3,000 publications on probiotics. So interest in probiotics have gone to a large extent into probiotics. Many people are doing research and trying to find where there is a role and where there is not a role. So actually, is there a hope with probiotics, or is it all hype that I will try to decipher in my presentation? So what determines hope? Whether there is disease in the question, which probiotic, single, multiple, dose, strain, credibility of scientific data, whether there are data which is being furnished by various studies, is it credible? What is the angle of analysis? Is there a bias? Or there are other aspects which are there like placebo effects and pharma kickbacks. So why are we confused? Because there is vested interest of authors. If you see, some authors are only interested in one kind of probiotic, others are only interested in one kind of probiotic. There is head-to-head trials are very limited in this segment. Positive outcome studies are usually pharma-funded trials. If you see in the disclosure, they are saying that they are associated with certain brand or they are certain, and there is lack of own data. So we do not have our own Indian data in terms of probiotics. That is why we are depending on the Western data and we are extrapolating their results into our data. So probiotics in children is basically, if you see, a combination that allergy, genetic and functional, and the infection are all in a vicious circle. and they lead to gut pathway. Use of probiotics is basically a therapeutic use, a prophylactic use, but we have to always consider what is the efficacy and safety of a probiotic. So considering these things, we have to balance between what is their role actually and what is their efficacy and safety profile, and also the cost benefit analysis has to be done in terms of probiotics. Now coming to the first clinical indication, necrotizing enterocolitis. What we see understand is that in necrotizing enterocolitis can be prevented. So in necrotizing enterocolitis, it is basically probiotics have a role in prevention rather than cure. So it has been seen that can we prevent. We all understand that late onset sepsis, very low birth infants are prone to NEC, and they have to undergo, and if the child develops NEC, they have to undergo surgery, and mortality is very high, 20 to 30%. So we have something in probiotics which can help to save this outcome of these children. So a 2-day-old child who presented at 34 weeks, born to a spontaneous, uncomplicated pregnancy, received standard newborn care, including vitamin K. His history was otherwise normal. So what factors do you consider most likely to present in an infant? What are the factors which can cause? So like maternal health during pregnancy, breastfeeding, are they taking, or possible GI cause? इनमें से कौन से फैक्टर्स हम सोचते हैं जो कि NEC को डेवलप कर सकते हैं एक नॉर्मल बच्चे में? So what does say that heterogeneity postnatal policy strain dose is important. So that is important. So if you see probiotics for preterm infants, a strain specific systemic review and network analysis showed that, which was done in 51 including 51 RCTs, they have found that there is effective mortality reduction in necrotizing enterocolitis, late onset sepsis with the introduction of probiotics. So the probiotics are a beneficial effect in prevention and reducing mortality related to necrotizing enterocolitis. So if you have a child who is preterm, we know that this child can land up into NEC. It is very prudent that we start these children on probiotics. There are the possibility of eligible study, but yes, there is a grade 2, grade 3 evidence that yes, these probiotics are helpful. So probiotics, do you agree with probiotics is safe for preterms with NEC? What does ESPGHAN say? ESPGHAN say yes, there's a low evidence of certainty, but yes, the probiotics are safe. So we can give these organisms, we can give preterm children probiotics if it is required in them. So which probiotic which is helpful is L-raminosus, and combination of Infantis, Lactis, and Staphylococcus have been tried. And yes, there is low evidence of certainty, but yes, they reduce NEC stage 2 or stage 3 in their studies. So we can recommend, no particular recommendation for single, and optimal duration is not known. What usually is given in NEC is 4 to 6 weeks, or until the discharge, child is going discharge, you should give probiotics. So which probiotics, what we already said, that these are the probiotics which can be helpful in NEC. Coming to probiotic strategy to prevent NEC, it has been shown that prevents NEC, gut-associated sepsis, and overall mortality in around 5% of cases, specifically children who are less than 32 weeks. So American Gastroenterology Association recommends that in preterm, low birth infants, we suggest a combination of lactobacillus and bifidobacterium species and bifidolactam species in combination probiotics in children who are prone to NEC, and is highly recommended. So what are the gaps? There are still, as I said, that no probiotics generally lack head-to-head comparison. More data on less than 28 weekers, which are most prone to NEC, is not there. And how do we administer, whether powder or liquid, microbiological safety? All these are still gaps in research, which can be tried in future research programs. Coming to acute infectious diarrhea, which is the most bulk of prescription of probiotics, we understand that there is a tug of war between different areas where some people of Western Europe and other can say that you should not use probiotics, but Eastern Europe countries propagate the use of probiotics. So reasons for heterogeneity is that there are different studies, like study in India or study in Western countries, are entirely different in terms of the assessment, in terms of the Human Development Index, they might have a different. So all these factors come into play when you study, do plan a study on probiotics. So if you see a 3-year-old child diagnosed with acute gastroenteritis, I would always recommend that whenever there is acute gastroenteritis, we should always start with zinc, ORS, avoid any unnecessary drugs, and continued feeding. So this is the cornerstone of acute gastroenteritis. So what is the appropriate action? So do you start probiotics? Do not start probiotics, or you just provide supplementary care, supportive care in terms of hydration management, and combine later with probiotic? So what is done basically? So measures or efficacy on probiotics, which is there, practically for mother, it is duration of diarrhea, volume of stools, and duration of. Whereas if you see research, it is modified risk carry stool. So what we have found is that SPGAN says that there is quality of evidence which says that probiotics are helpful to a certain extent in conditions of improving in acute diarrhea, whereas certain probiotics are against recommendation and should not be used. So if you see Lactobacillus rhamnosus disease, Aspergillosis, Bacillus clausii usually have a weak recommendation, but yes, they have a recommendation in terms of acute diarrhea patients. Similarly, is American Gastroenterology Association also saying the use of probiotics. So verdict is that in children with acute infection diarrhea, we suggest the use of probiotics, conditional recommendation with moderate quality of medicine. You may add on to the standard ORT in acute infectious diarrhea, which will help to reduce the day 2 frequency of diarrhea and also persistent of diarrhea beyond 4 days. Then these are various studies which are there along of ALIGARH. However, what we need to understand that majority of the studies have predominantly done in milder variety. हमारी इंडियन सेटिंग में हम बहुत सीवियर डायरिया देखते हैं. ये जितनी भी स्टडीज है सब वेस्टर्न वर्ल्ड में हुए जहाँ पे बहुत माइल्ड डायरिया होता है. सो माइल्ड डायरिया तो हमारे में हम लोग के मोस्ट ऑफ द पेशेंट्स तो माइल्ड डायरिया के लिए हमारे क्लिनिक पर आते भी नहीं है, वो अपने ही घर पे ट्रीट हो जाते हैं. Whereas in Western countries they have access, easy access, so they go to the doctors and वहां पे सारा स्टडी करा गया है. So our data of severe diarrhea, whether responding in severe diarrhea is basically we do not have in terms of these studies of Helveticus and Lactobacillus GG. So we are not sure whether actually these probiotics will be helpful in severe variety, which we are basically concerned. जो severe diarrhea करके आते हैं, severe dehydration में आते हैं, क्या उनमें भी probiotics have a beneficial effect, because there the life threatening is all the more, mortality is more high. So considering this, what have been found is that Asian perspective, reduction in duration by 24 hours, higher dose better than lesser dose, and similar proportions in Asian and Europeans, and most effective in introducing less than 72 hours. So अगर हमें डायरिया देना भी है तो हमको earlier डायरिया के पेशेंट को देना है. जितना हम देर करेंगे उसका इफेक्ट उतना कम होता जाएगा. If you have to give probiotics in a diarrhea, please give it as soon as possible. Saccharomyces boulardii are limitations because of poor design, so it is not so much recommended. Bacillus clausii again offers you a duration of diarrhea reduction by 9.2 hours, hospitalization by less than 0.84 days, and recovery was achieved by 97%. So this is beneficial in terms of Bacillus clausii. Rheumatoid, there is no Indian studies, so effectivity we cannot say. The summary of Indian studies shows that there are multiple RCTs which have been done, and all of them show a moderate effect. That is why the recommendation is that you can give them as an add-on therapy to the standard ORT rather than not giving them or giving them unjudicially in every case. So pooled Indian data also shows that Bacillus clausii, Saccharomyces boulardii have a low to moderate effect in existent level, but have a poor impact. So, and no combination. Very important that in the market there is combination probiotic available throughout the market, which is not of much use, and it has not found to be suitable. So we should avoid use of combination of probiotics. Coming to other diarrheas like antibiotic-associated diarrhea, Clostridium difficile, nosocomial, inflammatory bowel disease, probiotic supplementation we'll be discussing. So on antibiotic-associated diarrhea, it is recommended that 2-strain or multiple strain probiotic can be given and is helpful in overall improvement. Other diseases like ulcerative colitis, Crohn's disease, there is no role of probiotic, and therapy of Clostridium, there is no role. However, in pouchitis, which is a post-surgical usually considered after colectomy, higher dose of VSL3 is recommended in cases of pouchitis. Coming to nosocomial diarrhea, Lactobacillus rhamnosus GG has been beneficial to prevent nosocomial diarrhea in children. But what literature, if you go back deep into literature, most of these recommendations are based on analysis which are basically pharma participant, and so we should always keep our uh, work open, and we should always think our own guidelines. Coming to pediatric allergies and asthma, probiotic supplementation do be given in all these cases. So what we can say is that generally all these are basically uni studies which are done. Benefit is still not evident in terms of atopic dermatitis, food allergies, and asthma. So blanket recommendation that probiotics should be given in all these cases should be avoided. Functional gastrointestinal disorders like infantile colic, abdominal pain, irritable bowel syndrome, regurgitation, and constipation. I would say infantile colic is one where there is a role of Lactobacillus reuteri. However, it was done in only exclusively breastfed infants. So, in exclusively breastfed infants, Lactobacillus reuteri has some effect, but if the child is on predominant mixed feeding, then the effect is not good. So you have to give, if you have to give Lactobacillus reuteri, it is effective in only those subset of children who are exclusively breastfed, rather than those who are mixed breastfed. Irritable bowel syndrome, the quality of evidence is very weak, so should not be given as a treatment of choice. So what I can say that recommendations in terms of probiotics, if you are using for preterms for NEC or antibiotic therapy diarrhea, you should use, and pouchitis should use. There is low evidence in acute diarrhea like of Lactobacillus GG, SB, but if along with ORT, it can be tried. In infantile colic, Lactobacillus reuteri. However, there is no use of giving probiotics in IBS, functional abdominal pain, food allergies, persistent diarrhea, inflammatory bowel disease, and Clostridium difficile therapy. Thanks.
Thank you, Dr. Shirish. You have very nicely explained the role of probiotics in different conditions. But I have seen this probiotic are very helpful in IBS.
Okay, sir. So basically, that is the adult data which we on which basis we do give in adolescent also. The adults have shown a lot of beneficial effects in probiotics. But when you see it in pediatric practice, specifically if you see the spectrum of IBS in pediatrics is basically functional abdominal pain. So in that respect, we have not found probiotics to be actually helpful. But if you say that IBS, constipation, diarrhea predominant type, which is in adult mostly or adolescent, which is beyond 14, 15 years of age, who have recurrent episode, there has been a beneficial, but generalizing to all functional abdominal pains or only with pains, then the probiotics have a limited role.
Or what about this natural prebiotic curd?
Yes, sir. That I want to really emphasize is that, first of all, there are two types of curds which are available in the market. One is the curd which we are basically of a pasteurized milk. If you are taking a pasteurized milk and then you are usko hum jama rahe hain, to pasteurized milk mein already we have killed the bacteria. That has been pasteurized. Once it is been pasteurized, you have already killed the bacteria. जब आप थोड़ा सा उसमें दही ऐड करके उसको ऐड करते हो, so you do not get that sufficient quantity of bacteria. However, what our elders were taking were not pasteurized milk. They were taking the pure milk, which had their own bacteria, and we used to, जब हम उसको कर्ड करते थे, तो उसमें कंटेंट ज्यादा थी. हमारा जो इस समय मिल्क का जो हम बना रहे हैं कर्ड, वो has a very small quantity of bacteria because we have already pasteurized the milk. हम पैस्चराइज भी मिल्क यूज करते हैं, फिर हम उसको बॉईल भी करते हैं, उसके बाद हम उसका दही जमाते हैं. जब हम इतना ज्यादा किल कर दे रहे हैं बैक्टीरिया को, तो हमारे पास उसमें बैक्टीरिया लोड ही नहीं रह गया. वो दही तो रह गया, लेकिन बैक्टीरिया लोड बहुत कम हो गया. सो आइडियली सब्स्टिट्यूटिंग इट फॉर अ प्रोबायोटिक इज डिफिकल्ट बिकॉज हम उतनी क्वांटिटी में नहीं दे रहे. इट इज सेम लाइक गिविंग पैरासिटामोल. हम 40 kg बच्चे को अगर हम 100 मिलीग्राम पैरासिटामोल दे रहे हैं तो वो इफेक्टिव नहीं होगा. सो वही चीज है कि अगर हम लिमिटेड क्वांटिटी में दे रहे हैं तो हम एक्चुअली उतना अमाउंट ऑफ बैक्टीरिया नहीं दे रहे हैं जो आइडियली जाना चाहिए, जो कि हमारे फोर फादर्स जब दही खाते थे उनका दही डिफरेंट है, हमारा दही डिफरेंट।
असल में मेट्रोज में अब सारा पास्चराइज्ड ही आता है
बिल्कुल
ऑलमोस्ट
सर,
इन मैनी सिटीज।
सब
तो
जगह यही है। तो हम दही को सोचते हैं कि हम अच्छा प्रोबायोटिक ले रहे हैं, बट एक्चुअली हम वो अच्छा नहीं ले रहे हैं, क्योंकि
नहीं
वो
ले
पास्चराइज्ड हीटेड मिल्क को जमा रहे हैं, जो कि बहुत कम प्रोबायोटिक रहेगा, उसमें एक्चुअली बैक्टीरिया बहुत कम रहेंगे।
पास्चराइज्ड एंड बॉइल्ड रीबॉइल्ड।
हाँ, पॉइस्चराइज्ड बॉइल्ड रीबॉइल्ड मिल्क को अगर आप जमा रहे हो तो उसमें बैक्टीरिया का कंटेंट
हाँ, इट विल
ऑलमोस्ट
किल ऑल
नेग्लिजिबल
द
हो जाता है।
बैक्टीरिया। एनी अदर क्वेश्चन फ्रॉम द ऑडियंस?
Sir,
नमस्कार, हम कैसे हैं?
sir, sir, my question is regarding to pediatric neurology. Many companies claiming that probiotics helps in the autistic spectrum disorder or attention deficit hyperactivity disorder. What is your take on that, sir?
Yes, that is what I was saying, that all these, if you saw the second slide was basically that हमारा research from 1993 to 2020, 2012, 20 years में, there were only 2000 publications. But last 7 years में, there have been 3000 publications on just on probiotics on different aspects. So there is a lot of hype about probiotics in different spectrum. IBS, हमारा gastroenterology देख लो, या तुम्हारा asthma देख लो, allergies देख लो, या neurology देख लो, autism, इतना ज्यादा किसी ने कहीं भी एक स्टडी कर ली और फिर उसको हर जगह एक्सट्रापोलेट करना चाहता है, क्योंकि देयर इज लॉट ऑफ फार्मा किकबैक आल्सो ऑन ऑल दीस थिंग्स. देयर इज अ रोल व्हिच हैज बीन देयर, सो वी ट्राई टू एक्सट्रापोलेट, बिकॉज़ जब भी आप ये सोचो जिस डिजीज का ट्रीटमेंट नहीं है, उसके लिए कोई भी एक ट्रीटमेंट अगर आएगा तो वो बहुत हाइप हो जाएगा. If you say
Even
autism has no definite treatment, it's no definite drug. Say, I say for functional abdominal pain, it has no definite drug. It is mainly counseling, it is basically behavior therapy, it is mainly, we do not have a definite drug. If there is a definite drug to a disease, there will be no confusion.
obviously,
अगर
sir.
मुझे मालूम है कि हाँ इसका ड्रग का ये ट्रीटमेंट है, फीवर का पैरासिटामोल है, डेफिनेटली देयर विल बी नो कंफ्यूजन. कभी कंफ्यूजन हमारा स्टडीज पैरासिटामोल पे नहीं आता. वही हमारा कंफ्यूजन हमारा किसी जिसका डेफिनेट ड्रग है उस पे नहीं आता. विल्सन पे कोई कंफ्यूजन नहीं आता, हमको ये ड्रग देना. कंफ्यूजन वहां आता है जहां भी डेफिनेट ट्रीटमेंट नहीं है. वहां देयर आर एन नंबर ऑफ रिसर्च गोइंग ऑन, and then the confusion comes up. So still it's all literature. As far we do not deny that there is no hope to it, but till now I would say for all ancillary things like eczema, asthma, autism, it is still a hype rather than hope. Over the years it might change, so that is what we need to take it.
Are there any RCT studies over that?
I
Till
don't
now?
think I've not gone through them. Maybe I'll have to look specifically for autism, but कोई करना नहीं चाहता, कोई करना नहीं चाहता. Issue is that doing an RCT is a big challenge. Nobody wants to do it. A head-to-head comparison नहीं मिलेगा आपको. RCT तो दूर का बात है. RCT तो तब बनेगा जब कोई पहला एक head-to-head comparison ही कर ले. Head-to-head comparisons are lacking, and then that is the need of the.
हाइप तो है ही आजकल, प्रोबायोटिक्स की हाइप तो बहुत ही है.
So there we need to be very cautious. What are the indications? हमें indication देखना है, probiotic देना है. General blanket नहीं देना है. अगर हमारा ये indication है और हमको ये probiotic उसमें useful है. So if we have acute infections, these are the probiotics which are good. If there is functional abdominal pain, do not give probiotic. So first see the disease and then treat. Probiotic के केस में उल्टा होता है. कुछ भी है probiotic ऐड कर रहे हैं. वो चीज गलत है. Let's see the condition, let's see the diagnosis and make a proper probiotic according to it.
So in previous times, only one probiotic was there, lactobacillus. Nowadays, there are lots of around 100 to 200 versions of variants of the probiotics are there. So, is there any really significant difference between lactobacillus or some action of the lactobacillus or any other probiotic?
So basically, if you see, there are so many things. There are multiple mimickers which have also come, which actually do not contain the specific strain. If I talk about Bacillus clausii also, if you see now, many pharma companies are coming with Bacillus clausii. But if you say the original strains like Osin are not there in those, then these are racemic mixtures which are being produced. So once the patent had gone off, everybody started manufacturing. Earlier, it was only one or two which were manufacturing. But once the patent got off, After certain years, you can't retain the patent. 20 years, you can retain a patent. After that, you cannot retain a patent. So once the patent got off, OSIN, RT wala, jitne bhi sabne apne apna started making. And since there the quality got compromised. There the studies got compromised. So that we have to, whenever we are using, we have to use, like हम paracetamol भी अपना सोच के देते हैं कि हाँ ये brand देना है. Because we know that we trust this brand. Paracetamol is like a number of companies and manufacturing, but we still say that this is our effective. We feel in our practice this is the most. So that is the same with all probiotics also.
So some products comes as freeze-dried probiotics like VSL3.
Yes.
Difference.
So जो VSL3 है, that is a probiotics which is used mainly in adults. That is a combination. But जो VSL3 India में मिलता है, that is very small quantity. Actually, it is only 1/2 of actual the probiotic strength जो बाहर की European market पे है. The reason is that हम लोग की Indian जो FCCI है उसने इतना level of probiotics allow नहीं करा है. They say that कि इतना high probiotics might cause problems. So हम लोगों ने तो क्या करा, कंपनी ने उसका डोज रिड्यूस करके मार्केट में इंट्रोड्यूस कर दिया. And it is being used right, left, and center in adult population. VCL3 use कर रहे हैं. But actually, if you see, as also said in one of the slide, the amount of dose is less, and that might not be effective in conditions like pouchitis or inflammatory bowel disease, where it is actually recommended in Western literature.
Dr. Shirish, we have
Yes,
many probiotics. Can we say for any one of them that this is the best among all?
No, sir, we
Or-
cannot say. We
No.
cannot say in the sense that we do not have a head-to-head comparison. जब तक हमारे पास एक बड़ी अच्छी स्टडी हो जिसमें हम सारे स्पेक्ट्रम को ले, डायरिया भी ले, persistent डायरिया भी ले, क्रॉनिक, और फिर हम एंटीबायोटिक एसोसिएटेड डायरिया दे, सफिशिएंट नंबर्स ले ले, और हम 3-4 प्रोबायोटिक सबको एक साथ अलग-अलग ग्रुप्स में बांटे, तब तक हम बेस्ट का नहीं एनालिसिस कर सकते. और एक सिंगल स्टडी भी बेस्ट नहीं कह सकती. Once you have a proper 4-5 studies coming from different regions of India, नॉर्थ का अलग पॉपुलेशन है, साउथ का अलग है, वेस्टर्न अलग है, सेंट्रल अलग है, कश्मीर का अलग है. So once we have all these geographical variations, genetic aspects might cover, we cannot say what is best or not. Till that time, we have to rely on more data which is available, indication specific data. अगर हाँ कोलिक है तो रूटरी देना है. There is clear cut that one of the probiotics which is helpful in colic is Rutri. So you try Rutri in that. There is no other proven therapy as such or beneficial therapy. So we try that. Acute diarrhea, these are 3 which are available to us, which are proven good. Rest all are racemic mixture, we should not give them. So मेरा तो बेसिक ये है कि जो नहीं देना है पहले हम वो समझ ले. हमें racemic mixtures नहीं देने हैं, हमें low dose, low quantity probiotics नहीं देनी है, हम single strain probiotic दें जो कि effective है. That is individual prescription, physician's choice.
Any other question from the audience? So we can finish it now. Thank you,
sir.
Dr. Shirish, for a very nice and explanatory lecture, and you have cleared all the doubts. Thank you once again.
Thank you, sir. Namaskar.
Thank you, DIAP, for giving us this opportunity to hear you. Thank you.
Thank you, sir. Thank you, sir. Namaskar.
Namaste.